Hi there, my name is Cheyenne and this is my team,
Hi, I'm Josie.
Hi, my name is America Burnett.
and we will be walking you through our case study today. I'm going to share my screen and let's begin. Here we go. So today we will be talking about the opioid epidemic and its ethical implications and different ways in which we can modify different policies and incite policies to better this circumstance. I'll begin with the presentation of facts and then we will go into Josie's work and America's work. So the facts of the opioid epidemic: opioids are strong pain medications or pain relievers used to treat various types of pain, including cancer pain, chronic non-cancer pain, and acute pain caused from injury and other things such as that. There are two types of opioids: synthetics and natural. Natural opioids are derived from the opium plant. And then the most common synthetic opioids include Oxycontin, fentanyl, and heroin. Some of those you may have heard of as illegal drugs, which they are, and others are prescribed over the counter as pain medications. In the USA, 2.4 million people can be classified as having severe opioid disorder. This includes a reliance on traditional medicines and uses of heroin. At least 1 million of those people, and probably more of those individuals with OUD, are not receiving proper treatment or care that they're needing, and it's really a problem in the United States right now and across the world. So a timeline of facts to line up the opioid epidemic for you guys and understand maybe some of the major portions of this problem that we've been seeing for years. In 1990, opioid usage changed and were extended to chronic non-cancer pain patients. So that means that they could be prescribed to anyone in severe pain, not just those people seeking cancer treatment. From 1990 to 1995, the usage of opioids increased by at least 2 to 3 million opioid prescriptions per year. And that may not seem like a large amount overall, but in those years, that was a huge cause of the opioid epidemic. In 1995, Purdue Pharma approved to produce and sell oxytocin, a type of oxycodone, and then they claimed it was non-addictive. So that really increased a popular use of a specific opioid, and that really hurt the population and really spiked the pandemic. And from 1999 to 2010, 630,000 people died from opioid overdoses, making that the first major wave of the opioid epidemic, which we see continuing. The problem just isn't ceasing, it's just continuing on in the States. Pharmaceutical companies have a huge role in the opioid problem. Not only are they convincing their doctor representatives to speak to doctors, the doctors are then ultimately reaching out to customers and providing a resource for them to have these harmful addictive drugs. So the process goes that the big pharma companies such as Purdue, and there's many others, speak to their reps, then the representatives spend a lot of time with doctors, and then doctors prescribe things to customers or customers or patients, and then they end up on the streets, people sell them or they take them individually, causing a massive problem. The governing body of big pharmaceutical companies, or the FDA, we all know what the FDA is, recommends that opioids be used as a start low and go slow kind of treatment. So that means prescribing small doses and slowly using them, not just prescribing these large amounts that are being given. Pharmaceutical companies, despite that, are showing these drugs as non-addictive and prescribing them in large amounts, which is not healthy in any way. And then the FDA also states that opioids should be used as a last resort kind of treatment. And pharmaceutical companies, such as I mentioned earlier, Purdue Pharma, seem to be ignoring it based on their advertising and representation to doctors. Doctors and representatives, like I just mentioned, play a huge role in this epidemic that we're seeing. In 2010, HCA, one of the largest pharmaceutical facility organizations in the country, increased its survey's role in the basis of funding for its hospitals. And that survey specifically was focused on pain and how much medication people were receiving for pain. So the better scores they received on those surveys, the more funding they had, the higher paychecks and grants were to hospitals, and the more people were having access to these opioids so that those survey scores were higher. In 2013, national survey stated that 74% of opioid users acquired their prescription directly from doctors, or they acquired their opioids from friends or relatives. But either way, those opioids were still coming from large amounts of prescriptions from doctors. As pharmaceutical companies have increased their rep time with doctors, so their representatives' times with doctors, they're able to convince doctors to prescribe more of these opioids and allow them to be out on the market. So overall, what we're seeing is a large increase in opioid prescriptions. We're seeing a large increase in pharmaceuticals traditionally and still providing advertisements stating that these drugs are non-addictive, and then they're still getting into the hands of people that are using them in addictive ways. And doctors and representatives are taking this information, giving it to patients, assuring them that things are non-addictive, and then their drugs are being put out on the streets. They're being given to patients anyway for pain management. And the overall use of opioids seems to be very large in the United States right now. I'm going to move on and move everything over to America, and she's going to speak about the different ethical concerns of the opioid epidemic. Thank you.
So, yeah, like she said, I would like to kind of cover the ethical concerns around the opioid crisis, starting with the marketing of these drugs. So, on Cheyenne's timeline, the sales grew from 1996 to 2000 from $48 million to $1.1 billion. So, at the beginning, these pain management and speaker training conferences at resorts, that was kind of how they brought in thousands of pharmacists, doctors, and nurses that attended these all expense paid kind of seminars. And so our textbook talks about how people that work for the US government can't even accept a free meal because it could be considered a bribe. And yet Purdue is bribing doctors with all expense paid resort stays. And that's not even where it stops. So they also have a sophisticated marketing data to influence physicians prescribing. So basically in today's world, data is everything. And Purdue used this strategy where they targeted physicians who were the highest prescribers, meaning this, that basically translate to their database identified the least discriminate prescribers in order to bank on their irresponsible discretion. Next slide. So, can we go to the next slide?
I'm sorry, I'm trying to get it to go.
Oh, no, you're good.
An issue. There we go.
Okay, so basically, Purdue claimed that the risk of addiction for OxyContin was extremely small. They actually had a less than 1% risk of addiction sales message. That's what they taught their sales reps to say when speaking to doctors to make them feel comfortable just prescribing them. The company cited a study on burn victims to prove their statements, but the study had no insights on the risks of addiction when opioids are given to people that are just treating it for daily chronic pain. So while the study that they cited never actually shows that patients are highly addicted to these opioids, we now know from new studies that the risk of addiction can be up to 50%, depending on the subpopulation that you're studying. Next slide. So basically, the ethical concerns also go into the incentive programs that they outline. So first, they implemented aggressive incentive programs in their sales reps in order to maximize sales. So these bonus incentives started from $15,000 to $240,000, and that's on top of their base pay. Those are all bonuses. Then when you realize you can only make so much money off of prescribing opioids to cancer patients and burn victims, you have to create a broader market for yourself. You have to start treating all kinds of pain ailments. And they went as far as to offer free limited time prescriptions for 7 to 30 day supplies of OxyContin. And so 34,000 coupons had been redeemed by patients nationally. That's kind of how seriously they were taking it. Um, and in 2014 to 2015, opioid manufacturers paid hundreds of doctors in the country six-figure sums for speaking, consulting, and other services. But thousands of doctors were paid over $25,000 during that time. Basically, the end of this basically turns out that doctors who prescribe more receive more monetary incentives. Next slide. So the ethical concerns, what does all of this mean? So at the root of this, it's pretty simple. It's a conflict of interest. And our textbook actually refers to a conflict of interest as a structural situation in which one person occupies multiple roles that have the potential to be at odds with one another. And in this situation, it's the doctor's interests versus patient's interests. So most of this is structural, and the pharmaceutical industry created a conflict of interest between the doctor and the patient. And in this case, it resulted in the blatant disregard of real life implications of this crisis. So, what are these real life implications? The real life implications is when I was 10 years old, visiting my uncle in the hospital because he almost died of a drug overdose. The real life implications is when I was 14 and I went over to a friend's house and I asked her why there was a safe on their kitchen counter. And she said, "Oh, that's where my dad keeps my mother's pills." If you want to talk about the real life implications of this conflict of interest, those are the real life implications. And we have a long way to go to reverse these implications.
Okay, so I'm going to cover some of the legal implications on a federal and state level. Some of these is talking about what they've done. Some of these things are in process, and then just a couple improvements at the end. So first off, so the federal government holds broad power over the healthcare industry. So they have a few different administrations, groups that have done different things during the opioid crisis. So first is the Food and Drug Administration. So the first enactment of the Food and Drug Administration was in 1906, and it was a law that disallowed interstate shipments of adulterated food products and misbranded drugs. So basically, the FDA was started to help with labeling. Today, they focus more on pre-market approval of food and drugs, but because now mislabeling is illegal. But with the opioid epidemic, at the beginning, the FDA followed the Health and Human Service guidance. This involved educating professionals about questionable prescribing practices, requesting stronger labeling from the pharmaceutical companies, and ensuring that first responders had Naxalone, or also known as Narcan, and that is a drug that is used to reverse the side effects of opioids, so something that they would use if someone was overdosing. Also, the FDA created the REMS program, Risk Evaluation and Mitigation Strategies. This is a voluntary program, basically educating professionals about appropriate opioid use. But they did a 2016 evaluation, and it looks like only 1/3 of the people or the professionals that the FDA was targeting were actually using this program. So whether this was an effective program is still up in the air. And lastly, the FDA also called for the removal of a drug called Opana because there were questions of its appropriate use. So they decided to get rid of it. Then we also have the CDC. I think we all know about the CDC now because of COVID, but they are normally an infectious disease administration, or But they decided to get involved with the opioid crisis because it was affecting so many people, and it was so widespread. So in 2016, they released their guidelines for prescribing opioids for chronic pain. So this was aimed at doctors who were prescribing for non-cancerous pain. And the CDC recommendations begin with wanting to limit patients' initial exposure to opioids. So therefore limiting dependence overall. They think if you don't need the drug to feel better, or if your pain is not, can be managed elsewhere through non-opioid therapies, then just let's limit the exposure. Let's not, and limit the dependence and not start you on the drug beforehand. They also recommend limiting dosing and duration. So, the longer that you are on the opioids, the more likely you are to get addicted to it. And then we have the Drug Enforcement Agency, and they actually have the most authority when it comes to drug laws in the US. And basically their job in a nutshell is to work to reduce drug supply. This can be done through illegal and legal drugs, basically trying to find pill mills and in those and stuff like that. So next slide. So then we have the state level. State governments exercise insurance oversights and retain authority for medical licensure. I liked this quote about overall what states have had to overcome, but they ultimately deal with the end result of the prescription drug abuse epidemic, overdose deaths, increased emergency department usage, increased law enforcement demands, and broken communities. So states really have been at the forefront and of having to create creative solutions to end this problem because they've had to deal with the end results. So they've had to come up with some creative solutions. So one of the biggest state level interventions has been the creation of the prescription drug monitoring program. This is basically an online database that collects information on prescription drugs. So if you're a doctor prescribing a drug, you would have the prescriber, the patient, and the dispensing pharmacy. The problem with this is that it's not consistent across all states. Some places aren't required, states don't require it at all. Others require it at different times of the year. Some may do like monthly, quarterly. It's just not very consistent. So the states aren't really working together on this. And then we have the continuing education requirements. So like I mentioned before, the states are in control of the medical licensure. So they could require continuing education on opioid use. They could also go further and teach how to properly use the prescription drug monitoring program and figure out ways to more effectively use that. And then we also have lawsuits. So there were lawsuits filed against the opioid manufacturers. This was from the states. This is some stuff that America and Cheyenne has mentioned, but because of the marketed minimized danger of opioids and exaggerating the long-term benefits for non-cancer patients, and all of these violate state law. So, and one good thing that could really come from this is that with these lawsuits, they could go into internal information of these drug companies. So they could look into their emails and communications and see if they really did know about the effects of these drugs and how they were lying whenever they were marketing and misleading people, basically. So yeah, next slide. Okay, so then we just have a couple improvements to policies. I've already kind of mentioned this, but better use of the prescription drug monitoring program. I think if it would really help if the states could get on the same page about this or just share data between each other, like what they see, because it's been so state by state, they haven't really been able to work together. on the information that they are gathering. And I also said more funding for education and treatment, because this is something also that could be good from the lawsuits, is if they got money, that they won and got money from them. And it would allow for more education, continuing ed for the doctors, and better treatment programs, and maybe even learn about ways to better prevent this happening again. So yeah, that's our presentation. Here are our sources.
Here are the multiple sources we used. And then also, if you are very interested in this topic, here are the links to our articles. Feel free to read them. They're all in academic journals and such. Thank you so much for watching our presentation. We hope we educated you on the opioid epidemic and gave you some insights into the ethical implications of it, and then also some possible policies that need to be adjusted or things that could be improved to cause real change. Thank you. Bye-bye.